Good evening. This is the special called Public Health and Safety Committee on Drug Dependence and Opioid abuse, and we're here tonight with several speakers. My name is Erin Evans. I'm the chair of the Public Health and Safety Committee. The speakers that we have this evening, we have Mary Lyndon Salter, who is the executive director of the Tennessee Association of Alcohol, Drug, and Other Addiction Services. We also have Josh Love, who's an epidemiologist with the Drug Overdose Response Unit with Metro Health, as well as Dwayne Holman from the Nashville Prevention Partnership. I also have a number of representatives from other Metro and non-Metro departments that I want to recognize just in case there are questions that come up that fall into some other areas of specialty. We have Sergeant Michael P. Holtz, who's a specialized investigations division with the Neighborhood Safety Unit of MNPD, Amanda Brock, who is an SVP with the Mental Health Cooperative, Inspector David Emhoff, who's with the Office of Alternative Policing Strategies and who runs our Partners in Care program, Robbie McAllister, Deputy Director of EMS Operations. And then we also have a couple of representatives from our law firm that has worked on the opioid settlement that was just announced today about Davidson County receiving $23 million as part of the opioid settlement. We have Mark Chalos, who's the managing partner of the Nashville office of Leif Cabraser, and then Isaac Connor, who is a partner with Manson, Johnson, and Connor, in addition to representatives from the administration. So our first speaker is Mary Lyndon Salter, and with that, I'm going to turn it over to hear from her to talk about addiction.
Well, hello, everybody. Yes, I am going to talk about addiction and the brain, and before everybody's eyes glaze over, this is not going to be like, learning the parts of the brain and all that kind of stuff. I do a presentation that's much more conceptual, so it's going to be something that I think you can learn from because it's very much about kind of everyday activities that you do and things like that. Let me tell you a little bit more about TADIS, though, before we go forward. We have a lot of resources at TADIS. I won't go into a lot of them, but at the very end of the presentation, you'll see a slide about the Tennessee Red Line, and there's actually a little Red Line phone on your desk. That is a statewide toll-free hotline where people can get addiction treatment referrals and information, including access to recovery housing, recovery support groups, and actually including mental health resources as well. Sometimes people don't always know what they need when they call, and we try to do a little bit of everything. So that's, again, 24/7, toll-free, anonymous, and available for any of your constituents should they have questions. But let me go to what I promise you is the most technical slide out of any that I'm going to present. This is kind of a representation of a neurotransmitter in your brain. And believe it or not, a neurotransmitter is nothing more than the way that your brain communicates with other parts of the body. It's a communication pathway. It's a transmitter and a receptor. And what I will point out on this slide is that you'll notice on the brain neurotransmitter, there's little nodules as you go down that pathway. And we're going to talk about those nodules a little bit more, about how it affects, or how opioids affect those neurotransmitters. But basically, I want you to think of a transmitter as just that communication pathway. Make sense? So there's bunches and bunches of those pathways in your brain. You can tell by the picture on the top. There's actually millions. They're categorized into functional kinds of categories in your brain, but there's two ways that your brain communicates, electronically and chemically. Electronically might be like how you move a muscle, for example. An electric signal actually makes your muscles move. But chemical signals are how you transmit thoughts. Believe it or not, you can't have a thought at all unless there's a chemical in your brain that transmits that thought down a neural pathway. And you've probably heard of some of those chemicals, like dopamine and serotonin, right? You can't be happy unless you've got dopamine and serotonin. And you probably heard of melatonin, right? Melatonin helps you sleep. That's actually a chemical that is transmitted down that neural pathway, and the signal gets sent, it's time to go to sleep, okay? So that's another one. You probably heard of others like cortisol and some other things, but each chemical is responsible for a kind of thought or a kind of thought pattern. Does that make sense? So brain functions can be altered by restricting substances like that or adding substances. So when you use a substance like alcohol or drugs, that affects how those transmitters are able to go down that pathway and transmit a signal. Making sense? Okay. So it's also important to know that the brain itself isn't altered when those pathways are affected. It's we have a lot of neuropathways. You're going to see this in a second. Here, I'm realizing I don't see everything the way I should. Okay. Why is it not switching? Oh, is it? Okay.
Got to be on the screen.
I was using this, but okay, there we go. So, a lot of people during COVID started gardens. So I'm hoping this visualization helps you make sense of what I'm about to say. But hopefully you've had a garden in your lifetime, and you know that when you plant a row of something, we'll call those carrots, okay? And you get out your hoe and you plant a row of things, you get out your hose, you put it down, you go to the spigot, you turn it like a quarter turn, right? That water is going to go down that row, right? It'll go down a defined pathway. You turn off the spigot and you come the next morning and you go and you turn it a quarter turn. Anybody want to shout out and say what happens? Turn it a quarter turn, it's going to go where? Exact same path, right? And the more you do it over and over again, that pathway is going to get deeper and deeper. And as long as you turn it on the same way, as long as you don't move the hose, as long as you don't get out the hoe and do anything to that row, it'll be exactly the same pathway, right? Well, that's exactly what happens in your brain. The more you do something, and the more you put in the exact same signals, the exact same thing, the thought, whatever, is transmitted the exact same way, and you get the exact same result, okay? And the more and more you do things, the more deep that rut is, right? What do you have to do to change that? You got to change your action. You got to get out the hoe. You got to move the hose. You got to turn it a half a turn on the spigot instead of a quarter turn, and then you'll get a different pathway. But if you don't change the input, you don't get a different outcome. Make sense? So that's exactly what happens in your brain. The more you do things, the more repetitive it is, the deeper that pathway, the harder it is to change it, actually, right? And then you have to do something demonstrably different in order to change the pattern. To change a thought in your brain, you have to literally reprogram it. Fair? So, we're going to talk about some automatic thoughts now. A little bit of a switch. But when you are born, you've already learned how to do a bunch of things. A baby already knows how to cry, right? It already knows how to eat. It already knows how to pee and poop and do all kinds of fun things, right? They're born with all of those neural pathways laid. They already know how to do those things. And all of those things are related to what we call survival center functions. That's what your body is programmed to do so that you can survive after you're born. Well, one of the things that's also a survival center function is pain. And when you're in pain, your body tells you you've got to do something to be able to survive. So just like when you get hungry, it's a huge craving to be able to figure out when you're going to eat next, right? If you've ever been hungry, think about that, okay? Or if you need to sleep or whatever, it's your body just automatically goes there, right? You don't have to think about it. You don't plan it. You do it. That's the same thing with pain. Pain tells you you're in trouble. Pain tells you you need to go to the doctor, you need to take your temperature, you need to do something. So pain is something that your body does and manages automatically, just like the other survival center functions. So think about that in terms of a survival that you have to deal with on a daily basis. Your survival center brain, those automatic thoughts that are pre-learned, pre-wired, automatic. Nobody taught you how to do any of that stuff. Those things are the things that your body reacts to automatically. You don't have to think. If you're faced with a lion, for example, and you had to stand there and say, gee, that's a lion. I should go somewhere. I need to find shelter. By the time you've said any of those things, you're gone, right? You're eaten. So that's the reason why those survival center functions are embedded in kind of fight or flight responses. Very automatic. Because if you think, you die, right? So this becomes critical when we try to figure out how to manage certain activities. But one of the things that your body does to regulate those kinds of survival center functions is, yes, your brain gets really lit up and all kinds of signals are being all over those neural pathways that I'm hungry, I must find food, I must, find whatever I need to be able to get to food, right? Those things are survival center functions. So you don't even think, you just react, must have food. But once you've eaten, your brain starts to be able to relax because you're beginning to be full. And then your thinking brain takes over and says, okay, you can push away from the table now. You can get a doggy bag. It's cool. And so survival center function isn't prominent anymore. Then it's thinking brain. And that's really important to regulating some of those activities and emotions. Okay, however, think about managing pain. Pain is a survival center function. Pain tells you you're in trouble. The problem with managing pain is that when you take something like an opioid or alcohol or something like that, it kind of it shuts down a lot of that those thought patterns. Opioids are very, very insidious in particular. That neural pathway that I talked about that had the little nodules on it, when an opioid gets into your body, it literally goes onto that neural pathway and blocks every single one of those receptors. So nothing can get through. An opioid literally blocks the ability of you to communicate anything on that neural pathway, okay? So that's going to block anything related, to any kind of thought patterns. This picture is a very famous kind of a billboard. It was in downtown Nashville for years, and it had like 10 different years of this woman's life. And I think it was supposed to illustrate kind of the insidiousness of addiction. But what it also illustrates to me is the fact that there's somebody who's been on this trajectory for years who doesn't see herself as actually deteriorating. What she sees is somebody who has to have more opioids to survive. Her brain is telling her she's in pain, must survive. No other thoughts get through. Is that making sense? So addiction basically disrupts the survival center of the brain. It disrupts self-preservation. It disrupts awareness. So a lot of people get really frustrated with people in active addiction because they think, like, don't you see yourself? Like that woman on the billboard. Don't you see how you're deteriorating? Don't you see that you've lost your job, that all these bad things are happening to you? And the honest answer is no. Because what they're faced with is a brain that tells them that if they're in pain, they must have more opioid. And the minute that opioid wears off, they have to have more. Must manage pain, must survive. Their brain is actually kicked into high gear around those things, and they don't manage anything else except their addiction. Okay? So one of the things that is particularly insidious about opioids as well is that the cravings and things like that are, and self-regulation, the ability to think through things are incredibly inhibited. And to be honest, I've said a lot of things that are already on this slide, but the ability of the prefrontal cortex, the thinking brain, to actually intervene in some of those things is incredibly inhibited. So, with addiction treatment, basically what we try to do is reprogram the brain and find opportunities where we can teach people new skills and help them use new neural pathways. For example, we help them try to manage pain differently and see pain differently so that survival center functions don't kick in and send them to using that substance. If they are taught alternative methods of thinking or processing information so they don't automatically go to that automatic thought, that deeply held belief that you have to have the opioid to manage the pain, then you can send them down a new neural pathway that gives them a different choice. Making sense? So one of the things that I also want to point out too is that the neural pathways, like I said, are blocked when you use an opioid. But because those receptors have been blocked, even if you're not using an opioid, the ability of those neuroreceptors to actually move a chemical down that pathway again is often inhibited for a long period, and it can take up to a year for somebody who's not used an opioid to actually regain full use of that neural pathway. It's really also insidious too. That's my favorite word for the day, I think, because the same neural pathway that transmits pain is also responsible for transmitting pleasure and happiness. So it's not only blocking your ability to build pain, it literally takes a year for a lot of people in addiction recovery to begin to feel happy again. And it can be very, very devastating when you work really hard on your recovery to not feel better, to not feel happy. You feel like you want to have that goal. You feel like, people are telling you you can get there. Think about, what goal have you had like that took an entire year for you to be able to feel better? So it can be a really a big issue for relapse when people, don't feel like they're ever going to feel good again. And the last time they felt good was when they used. So they often turn back to opioids to be able to just feel human again. Does that make sense? So this is a slide of brain functioning. The very top row is what's considered normal brain functioning. All kinds of firing going on. Those colors are because neural pathways are being used all over the place. The middle row is actually after 10 days of abstinence in recovery. So you can see not a whole lot of brain activity going on. And the bottom row is after 90 days. So still, really not a whole lot of firing going on, not a whole lot of receptivity, a lot of blocked thoughts. And again, we tend to blame people in addiction for why don't you want to get your life together? Well, this is why. Their brain is not functioning the same way that a person who's not used substances. So, yes, Gloria.
In typical recovery, there's a 30-day program, 90-day, 120. Rarely are they much longer than that. So when folks are going through that, are there ways to give them hope that sometime you will eventually feel, but
yes,
it's normal that you aren't feeling now? Because I would think it'd be so discouraging if you had got your 90-day chip and you still felt awful.
You still feel awful. That's exactly why people need treatment and not just abstinence, because they really need a counselor to help them reprocess those thoughts and to help them be able to find new ways of coping and to be able to see long-term goals. So, and those are very difficult. I'm not going to say that it's easy for people to focus on something that's going to happen, 9 months from now. But it's definitely true that that we work really hard in treatment to help people see the phases. You know, detox, getting all those chemicals out of your system is typically around 7 days. You might spend 30 days in a fairly intensive residential program. It's best to have 90 days of some kind of residential services and then transition to something that might even be like sober living or some kind of supportive environment, because they will need a full year of recovery to be able to get past most of the cravings. And anybody who's been in recovery will tell you, yeah, I got past the first year. That's a big milestone. But you know, every time something triggers them that sends them down that same pathway of thought, you know, they have a chance to use again. And so you need to have years and years worth of reprogramming to be able to have a deeper pathway, if you will, for the new lifestyle than you had for the old lifestyle. Okay? Did I completely do this? I guess I did. Okay. So I'm going to go back to my lion picture again and talk a little bit about trauma. Trauma is how a person experiences a very bad thing that happened to them. It can be emotional abuse. It can be for a child, let's say a 2-year-old who gets admitted to the hospital for cancer. It can be all the machines and things that come at them. They can't process it. They don't understand it. It's horrible. It can be the fact that you were in an airplane crash or a house fire or whatever that is. But we know that trauma and pervasive and continuous trauma lay down pathways in the brain so that people react in a very hypersensitive, hyper-aware fashion. Like they're always looking for the next bad thing to happen. The more bad things that happen to them, the more hyper-vigilant they are, and the more they're likely to react in a very negative way, because everything that happens to them seems to be bad, so they develop almost a perception that everything will be bad, because that's how their brain compensates to help them figure out how to navigate the world. When children are exposed to this, this really affects even their learning, because the more trauma that you have, the more you elicit that drug, cortisol, because cortisol keeps you vigilant for a reason. It helps you manage stress and things. Well, that's great, but while you're hypervigilant, you can't learn. Your ability to learn in a classroom is severely impaired because you're busy trying to figure out what's the next bad thing that's going to happen to me. You're not listening to the teacher. Your brain is someplace else trying to figure out how to stay alive, how to get home and not get beat up again today. Does that make sense? So as long as those things are happening, then you have an inability to learn. But you also have this rewiring so that if you experience bad things, you're going to assume the worst. And this is something where a lot of people turn to things like addiction because they use it to self-soothe, to manage stress and trauma. So addiction is almost, can be, it is, I think it's 75 times more likely to happen, you know, for people who've experienced long-term trauma. So there's a cycle here. Trauma, addiction, emotional triggers, and those triggers, like I said, the more you do something, the more you're going to repeat that pattern. So that's very important to help unlearn, but also to understand why people are repeating the same thing so you can send them down a different pathway. One of the things I try to do to help illustrate this, have you ever, for example, let's say you're driving to council every Tuesday night, you've been doing that for years, right? Have you ever shown up in the parking lot and then like, gee, I don't even remember getting here? Have you ever had one of those moments? Well, that's what your brain kind of does to help compensate. The more you do something, the less you have to think about it. And it's actually one of the things your brain does so that you can have room in your brain to be able to learn new activities. Your brain if it takes less effort for you to do things repeatedly, your brain doesn't have to consciously think about things. But so again, the more you do something, the harder it is to unlearn, right? True with addiction, trauma, all kinds of things. And I think I went the wrong way, did I? Yes. I'm going to take a quick minute and talk about addiction treatment. So traditional treatment is abstinence-based. It's about removing the thing that the person has been taking, and basically treatment is about helping that person relearn new activities, skills, and retraining the brain. Unfortunately, like I said, opioids are particularly problematic with that because they do attach to those neuroreceptors. They don't give the brain the same chances to recover. So what they do for people with opioid use disorder is medication-assisted treatment. Medication, in this case, can be, there's different compounds. You might have heard of Vivitrol or Naloxone. You might have heard of buprenorphine, Subutex, things like that. Those are substances that are given in order to kind of mimic the effects of an opioid so that people are not thrown into cravings quite the same way, and their thinking is still restored, and so they can take those medications for a year, sometimes 2, while they're in treatment to help retrain the brain. And because opioids are so, you're so much more prone to relapse using opioids because managing pain becomes something, again, that the brain just can't seem to get past, that the medication helps you get past those cravings and be more successful in treatment. But typically, those wouldn't be a long-term resource. You just use it until you have those skills developed. Make sense? Okay. One of the medications that we give for medication-assisted treatment, Vivitrol, is also the same medication that people are given when they're in an overdose situation. The nasal sprays and things are given to relieve the overdose, but they also immediately throw people into withdrawals. It literally kicks the opioids off their receptors, and so they are immediately craving more and more opioids, and they're in pain. So it becomes frankly, it's a really hard thing for first responders to understand. You know, they just saved somebody's life, and yet that person wants to go get high again. But they want to get high because they've immediately been thrown into that withdrawal stage. They're sick, they're hungry, and they're in pain, and they want to relieve the pain. So they're going to go for an opioid. Make sense? You sure?
So I forget what it's called, the medication that first responders
The Vivitrol.
carry with them, that's
Well, Vivitrol, it's Narcan or Naloxone. It's the same chemical, it's just different trade names.
okay, because of the Narcan, I think is what we hear about. So you're saying that immediately puts a person into that state. Okay, I had no idea. I can understand differently now.
Yeah. Okay. That's the end of my presentation about the addiction in the brain. That was a very short one. I elaborate in an hour version and a 3-hour version. You've gotten the short version, okay? So if you have any questions or something comes up, just let me know. My contact information is on the end of these slides. You got a packet with my contact information. And I just want to take a quick minute and talk about some legislation that TADIS is working on. Do I have time? Am I good? Okay. So we have 3 bills that we're really working on this year, and I'm happy to say the first one, the Naloxone Access Bill, that is a bill so that the nasal spray that Gloria was just talking about, the Narcan nasal spray, can be more widely available to people in Tennessee. Right now, Tennessee law distribution is based on what's called a pharmacy practice agreement. So the pharmacy has to agree to distribute it on their own authority. We're moving Tennessee to what's called an open standing order so that the pharmacy doesn't have to have the prescription ability. Anybody can go to a pharmacy and buy as much as they want. Programs like TADIS or the Nashville Prevention Partnership or a school or a church can basically buy as much as they want and distribute it and to anybody and everybody they want to. So that law is what we're proposing this year. I'm happy to say it's already passed in the Senate, on the Senate floor, and this morning at 10:05 a.m. it passed in the House floor. It's going to be sent to Governor Lee's desk shortly, and it will have a July 1st enactment date. So being able to much more freely buy, distribute, and give away, honestly, and there will be grant programs that agencies will now be eligible for because they're able to distribute the product. So we'll have more access to free naloxone throughout the state. So that's a good one. The next one is about decriminalizing fentanyl test strips. There are little like paper test strips that people can use. In fact, law enforcement uses them a lot. First responders use them to be able to test a substance to make sure that whether or not it has fentanyl in it. Fentanyl is an opioid that's extremely, extremely problematic. It is much more powerful than morphine or many of the opioids sold on the street. And it's the fact that it's being introduced in a lot of pill manufacturing. It's being laced with everything from marijuana to vaping products to all kinds of things, and that's predominantly responsible for a lot of our overdoses right now. So being able to test for fentanyl so that you know what you're taking is something that is available in a lot of states, but because Tennessee made fentanyl test strips drug paraphernalia, made it illegal to carry it, we have not been able to distribute them or use them in order to help people stay safe. So this bill is intended to decriminalize them, and it's going to be heard next week in the House Health Subcommittee on Tuesday at noon. So hopefully you can follow that legislation. The next bill that I'm going to bring to your attention is about co-prescription of naloxone. What this bill advocates is that whenever a physician prescribes an opioid, we're asking that they offer a co-prescription for naloxone. So if you get an opioid, you ought to have the antidote for overdose. Again, it's an offer. They don't have to, they're not required to write it, but they are required to have a conversation with their patients, with some exceptions, like with palliative care and some other things. But basically, we want to make sure that people understand, how to get access to naloxone. So those are the three big bills that we're working on this year. And as I promised you, this is the Tennessee Red Line, and I'm definitely able to answer any more questions.
Yeah, how about any questions for Ms. Salter? Let's recognize Jennifer Campbell.
Thank you, Chair, and thank you for having this meeting today for us to get a great understanding of how drug addiction impacts the brain and the process for getting off of drugs and how. And so I guess my question is, how can we help locally? You mentioned these Senate and House bills in the state. How can we help? Is there something that we can do to complement these bills to help address the opioid crisis here in Davidson County?
Well, there is another bill that's being run this year around, for example, nurse practitioners are prohibited right now in Tennessee from prescribing MAT, with the exception of 2 treatment settings, community mental health centers and federally qualified health centers. And the bill to allow them to do that was actually introduced last year. For up until then, nurse practitioners could and physician assistants could not prescribe MAT. Now, interestingly enough, they could prescribe opioids, but they couldn't provide the treatment for opioid addiction. We're hoping this year that there will be additional access to that prescribing authority allowed in a bill that will let what's called an office-based opioid treatment center provide it. And if we can add on that next year and let addiction centers that are licensed also use nurse practitioners to prescribe MAT, that would be very helpful. What we have right now in Tennessee across the state is a provider shortage, and being able to figure out how to staff programs, whether it's with the janitors, the kitchen aides, or the physicians. All along that spectrum has been a huge problem. We've had treatment centers who've had to close their doors for short periods. We've had treatment centers. I know we just had a meeting today. 5 out of the 25 treatment center CEOs raised their hands and said they'd worked third shift recently because they had no staff to work the floors and to work with patients. So being able to figure out how to build a more robust workforce, I think, would be extremely helpful. And things like the nurse practitioner bill that would help us leverage some of those resources differently would be exceptionally helpful.
Thank you. Councilwoman Hauser.
When you mentioned that when the emergency responders give Narcan to a patient, that it immediately throws them into this feeling of pain and needing their drug, is there something else they could give them that would ease that? Or what do we do so we don't have this cycle?
Well, the exact same drug is used in medication-assisted treatment, but it's given a little bit differently. The Narcan that's given with an overdose is an immediate acting agent. When it's given for MAT, it's given in a 30-day dose that's in a shot. So I don't know if you are familiar with the kinds of medications that they give, and it basically dissolves over time, in your body. That's what happens with the shot. So with Vivitrol, you have to give a continuous dose for it to have that effect, and that's very hard to do in the field, unfortunately. There are several locations in Tennessee where first responders are linked with treatment programs or sometimes peer counselors, so that a peer counselor can go out and talk to that person about maybe going to an ER or maybe going the next morning to a treatment center for an admission or an assessment. Those have been fairly successful. In order to be able to do that, though, you have to have immediate access to a treatment program. And if you don't have that, then there's no place to refer them to. So we really do need a more robust treatment system that would allow that same-day access to be successful.
All right, any other questions for Ms. Salter? All right, thank you very much for coming this evening. We really appreciate your time. And our next speaker is going to be Josh Love, who's an epidemiologist with the Drug Overdose Response Unit in Metro Health. And while he's making his way up here, I'll just tell a little story. So last October, I was on Twitter, and I shared a Twitter post from the health department, and it was on drug overdoses. And then the next day, I got an email from the Drug Overdose Response Unit saying, "Thank you for sharing our post. Would you like to come in and learn more?" And so it was the conversation that I had at that meeting with Josh Love and Angie Thompson and other members of the team that has led us to this moment to have this conversation. Kind of prior to having this meeting, at our last council meeting, we did pass a resolution, RS 2022-1417, which was a resolution in support of life-saving responses to the recent escalating overdoses, largely caused by the widespread availability of synthetic illicit drugs. And so you're going to hear a lot of information from Josh about the data that he sees and the process that they undergo. But it was really eye-opening for me to learn in my district and in my community kind of how pervasive the issue really is. And so I appreciate, Josh, you taking the time to come in tonight. Thank you.
All right, thanks. Good evening. So I'm happy to be invited to be present here today to present. Thanks to Councilmember Evans for connecting with us last fall and really championing this issue and working with our program. I'd also like to express some gratitude for the Neighborhood Safety Unit with police, fire department's EMS, the Regional Medical Examiner, and Dwayne Holman from Nashville Prevention Partnership, among other partners that are really on the front lines and doing impactful work. I hope you leave today with a greater understanding of the drug overdose epidemic here in the county and the various things that we're doing to impact this epidemic. The data presented here today will portray the epidemic through the lens of public health and public safety, with the latter being on the front lines every day responding to this. So this presentation will be divided into 3 sections: provide baseline information on the local epidemic via historic trends, population characteristics, geospatial trends, substance trends, prescribing trends. And then the second section will briefly discuss our program and some of the work we're doing with community partners. And then finally, a brief call to action for council members. A lot of it, I believe Mary Linden touched upon, and I'm not much of a policy person, so I'm more in the data, but I'll put it out there and we'll see where it goes, okay? Okay. So a few published strategies and seminal reports which guide our efforts include, well, first apart, we need to acknowledge that addiction is a brain disorder per the DSM-5. We treat mental health and substance use in tandem, and we'll get into some information related to that. The National Drug Control Strategy really focuses on enhancing collaboration between public health and public safety. There's a commission on combating synthetic opioid trafficking at the federal level, involves many agencies, recognizing the urgency of this situation, how we need to respond to this rapidly evolving epidemic. The U.S. Health and Human Services Overdose Prevention Strategy, they present 4 priority areas, including primary prevention, harm reduction, evidence-based treatment, and recovery support. And then there's Public Health 3.0, which we've really modified it to Behavioral Health 3.0, where I work in our Division of Behavioral Health and Wellness at the Health Department. But it's an era of enhanced and broadened public health practice, which promotes cross-sector partnerships and timely, reliable, granular data to really drive data to action strategies. So for some historic trends, the opioid crisis is a publicly or nationally declared public health emergency, declared under the Public Health Service Act by the Secretary of the U.S. Department of Health and Human Services. It's one of 2 national public health emergencies. The other, can anybody guess? COVID? Yep. There's been several other public health emergencies declared going back 15, 20 years, but they're all usually at the state level and they involve natural disasters. In a recent speech, the director of the Office of National Drug Control Policy stated the following: "Clearly today we are at an inflection point where we are seeing more than 100,000 overdose deaths in a 12-month period in the United States. For me, it indicates a greater sense of urgency than there's ever been. If we do not act now, then more Americans will die." He went on to recommend we prioritize saving lives and then providing people the opportunity to enter treatment, and emphasize the importance of the public health and public safety partnership. Yes?
Do we know what's making the difference between, say, Tennessee and South Dakota?
It could be it's related to the substances in the area, population as well, but not necessarily. It's just a less densely populated area, which is evidenced in the rates and the number that we're seeing.
But we see New York down towards the bottom.
Yeah.
Population wouldn't be the issue there.
Yeah, I'm going to get into that in a minute.
Okay.
Yeah. Great question.
If they're doing something that's really good, we need to learn what that is and implement it.
It's a good point. And so I'll get to the figure on the right in a minute, but in terms of drug trafficking, while our focus is primarily on public health, you cannot ignore the illegal drug trade when discussing this crisis. Last December, the president declared the illicit drug trade a national emergency via executive order. And so in terms of the economic impact, according to the White House Council of Economic Advisors, the cost of overdose deaths in 2018 was almost $700 billion. In terms of a sea change, between the 1990s until today, we've seen the shift away from prescription opioids, the overprescribing part, and heroin to more synthetic opioids and stimulants is where we're at now. This evolution summarized below by the 4 different waves that I have on the slide. So wave 4 being what we're in now is this illicit synthetic opioids and stimulants. And as such, other factors driving this recent shift include the following. Illegal drug manufacturing has become easier to conceal, moving from the opium poppy fields to the laboratory, the synthetic age. The materials needed to manufacture synthetic opioids can be purchased online or directly from chemical producers overseas. Synthetic opioids are highly potent, cheap, easy to transport small amounts for large profits is what's driving, I'd say, what I've read about that. So the figure on the right shows overdose death rates by states, and this is the most recent 12-month period, as recent as September of 2021. As you can see, Tennessee by rates is fourth behind Kentucky, DC, West Virginia. And then you can see the other red column bar in the middle is the US rate. And during this time, if you just look at the number of deaths, Tennessee it was the 6th highest behind California, Florida, Ohio, Pennsylvania, and Texas. So rates obviously factor in population sizes, but yeah. Where are we at now? We're what I would consider to be the deadliest phase of this epidemic, fentanyl contaminating the drug environment. What is fentanyl? Mary Landon touched a little bit on it, but it's a synthetic opioid, very potent, 50 to 100 times more potent than morphine or heroin. And we're increasingly detecting it in toxicology reports amongst overdose deaths here in the county, statewide, and nationally as well. It's a polysubstance epidemic, and we'll get into the variety of substances that are contributing to overdose death and injury. That's what we're seeing. It presents an increased burden on critical touch points such as EMS response, police response, medical examiner, hospitals, treatment providers, on down the line. There's a variety of emerging substances and fentanyl analogs, which make it a complex and dynamic landscape to track. And in terms of years of potential life lost, which is it's an indicator of premature death, on average, over 30 years per decedent, which the inverse of that is the average age at death, you would say. So individuals, and we'll get into age characteristics, but tend to be in their late 30s to early 40s. And the figure on the right shows the number of just overall incidents, fatal or non-fatal, by quarter in the county over the last 5 years. And the vertical line there indicates when it was declared a public health emergency. And as you can see, and you'll see in the next several slides, things didn't really take off until the last couple of years compared to where we were in 2017. Oh, excuse me. So start with the first critical touch point of being local EMS. EMS activity peaked in 2020 and remained relatively consistent into 2021, both the number and rate of those requiring response. We've observed just an increase in overall response, the amount of naloxone given out, and the dosage per incident requiring naloxone, which is an indicator of more potent substances in the environment, which is what the figure on the right shows, going back about 2 years by quarter. So talk about emergency departments, or where sometimes individuals are transported following an overdose. Again, similar story. Both number and rate have increased over the last 6 years from what we can tell. On this side of things, we can see the shift from heroin to non-heroin opioids and stimulants, which is the figure on the right, as you can see there, the red line indicating non-heroin opioids. To speak about the connection between mental health and substance use, if you looked at 2021, out of approximately 30,000 mental health related visits to the emergency departments here in the county, about 23% of them involved a co-occurring substance use disorder. Now in this case, co-occurring substance use disorder can include like alcohol, nicotine, opioid, stimulant, et cetera. Yes?
On heroin opioids, could you just take 20 seconds or so to describe what is an opioid and what drug is not an opioid? Because I don't, when you talk about meth or different, is that an opioid or not? I don't know.
I have a slide coming up which breaks down the different drug categories. Sorry, yeah. But in that case, it's simply, so heroin is a type of natural opioid produced from the poppy plant, the opium plant. But then non-heroin opioids could include the semi-synthetic, which are your oxycodone or OxyContin, and then the synthetic opioids, which can be fentanyl, tramadol, methadone, et cetera. So yeah, there's a lot there. Good question. Okay, so to talk about suspected drug overdose deaths in the county occurring amongst residents, non-residents, we've seen both, again, the number and rate increase drastically, especially as you can see taking off in 2019. And then in a few slides, I'll show the increasing presence of fentanyl, which has coincided with that increase. And the reason we use this particular metric of just all the overdose deaths that have occurred in the county, regardless of residency, is to portray the overall number of incidents which require response by community agencies, which I've detailed previously. How do we compare nationally? So looking at CDC data where they published county-level overdose deaths, I think it's stopped sometime in the mid part of last year, a 12-month period. Out of over 3,100 counties in the country in 2020, Davidson County reported the 30th highest number of overdose deaths. And so, yeah. So the demographics presented over the next 3 slides will largely focus on age, sex, and race characteristics observed among fatal drug overdose population. And I didn't include non-fatal characteristics because they largely align, and that'd be a lot of data, and it'd probably confuse everybody. It's just a lot of graphs. But to start with age, looking over the last 10 or 11 years, average age of death has ranged between 42 and 45 years. By age group, the predominant age group is 35 to 44-year-olds last year. 5-year trends, so looking at rates by age group, we've seen the largest increases in the 15 to 24 and 35 to 44-year age groups. But as you can see, overall, everybody's increasing. There's not really any age groups that are on the downswing. It's just a matter of, unfortunately, how fast is it growing? In terms of sex or gender, number and rate of overdose deaths have been higher over this time period amongst males compared to females. If you'll look at some population characteristics in the county, Davidson County tends to sway a little bit female, I think 51 or 52%, but at least amongst overdose, injury, and death, it tends to skew more male. But as you can see in the figure on the right, both have experienced increases in overdose death over the last several years, but really increasing the last few years. So in terms of race, we've had approximately 3,800 overdose deaths in the county going back to 2010. Over that entire time period, 78% have been among the white population compared to the black population and other races, 21% amongst the black African-American population, and 1% among ethnic and other races. So while the number and overall rate of overdose death has been highest amongst the white population over the last 10 years, in recent years, we've seen an increase in number and rates of overdose deaths in the amongst other racial and ethnic minorities. So for example, between 2019 and 2020, the death rate amongst the black population increased by 70% compared to the white population, which increased by 23%. And as you can see, especially, that's why I really like to compare with this number and rate. The figure on the right showing the rate, it's really closed the gap, so to speak, in terms of overdose injury or overdose death in the county by rates. And this trend has also been reported at the state and national levels as well. So it's not local to Davidson County, it's at those state and national levels as well. This slide talks a little further about years of potential life loss. The figure on the right just shows, again, an 11-year period of what the average years of potential life loss per decedent. It's ranged between 29 and 33 years. It's kind of went up and down, so there's a slight increase. When we look at this by sex and race, we just see negligible differences, not much of a difference there. Right. So we'll shift to geospatial trends and present those by zip code here in the county. And this is available in our quarterly report we put on the website, so if you guys want to access that, that'd be cool. But in 2021, just looking at the number of overdose deaths by zip code, the 5 most prominent zip codes, as you can see there, 37115, 37013, 37211, 207, and 209. Our program, i.e. our epidemiologists, monitor overdose cluster activity in the county, so we can work with our public safety and prevention partners to work together to focus on high impact areas, so to speak. At any one time, looking back at the previous 3 months of activity, we monitor between 10 and 15 overdose clusters in the county. And cluster meaning overdose incidents that are occurring within a certain area, say a quarter mile, over a certain time period. So it really helps us dial in on more acute trends as opposed to more long-term trends that may have been happening a few years ago that are no longer applicable. So when we look at social vulnerability, which is the resilience of a community when confronted with external stressors on human health, and examples include natural disasters, disease outbreaks, pandemics, and these social vulnerability includes socioeconomic factors, including poverty, lack of access to transportation, et cetera. But when we look at that in terms of where our overdose activity is occurring, there tends to be a lot of overlap. When we look within the county, including factors such as health insurance and median household income, we also see an inverse relationship of more activity in areas where there's less access to health insurance, using health insurance less, and lower median household income. And so that's the figure on the right is a map of the CDC Social Vulnerability Index by census tract. And the darker shaded areas are those more socially vulnerable, and then the lighter shaded areas, or the more yellowish, are less socially vulnerable. Okay, we're going to shift to drug categories and substance trends, and a lot of this is driven by the toxicology results amongst the overdose decedents. We analyze that information. So we tend to stay away from opioid epidemic and focus more on drug overdose epidemic. And it'll become apparent in the next few slides of what we're dealing with, just the variety of substances out there. I've tried to break it down into 3 columns. I know it's a lot, guys, but you have your opioids in the far left column, and that's broken down by natural, semi-synthetic, and synthetic. And I provided a few examples that maybe you guys will recognize. And the substances shaded in red are most commonly detected, which I'll show on the next slide. Examples of stimulants include methamphetamine, cocaine, and several others. We track tranquilizers and depressants, such as benzodiazepines, sedatives, muscle relaxants, ketamine. We'll talk about xylazine, which I don't know if anybody's heard of that one before, but you're about to, and it's something else. So looking at these substance trends again, these are what was detected in the toxicology report amongst the overdose deaths that occurred in the county going back over 10 years. And as you can see, with the green line that starts around 2010, that represents natural or semi-synthetic opioids. And so early in the decade, such opioids were predominantly detected amongst overdose deaths. However, with prescription drug monitoring programs being deployed across the country to curb overprescribing, we saw, as you'll see, the yellow line or gold line in the middle, an increase in heroin-related deaths around the middle of the decade. However, starting in 2014, you'll notice the steep red line. The rise of fentanyl began locally, and other states across the country, the rise of fentanyl occurred at slightly different times, maybe a year before, a year after. But that's when we began to observe the drastically increased levels we see today, while heroin and your classic or natural semi-synthetic opioids dropped off. To a lesser degree, you'll see I believe it's blue and gray line, that represents methamphetamine and cocaine. We've seen a slight increase, albeit to a lesser magnitude in recent years here in the county. And again, this is a trend that's also been reported statewide and nationwide. So it's not specific, again, to just the county. We're just seeing this across the board. Okay, so let's talk about fentanyl a little more in depth. Again, a very potent synthetic opioid compared to heroin or morphine. It's been the primary driver of overdose injury and death that we've observed recently. It can be prescribed by a doctor or manufactured illicitly. When it's found illicitly, it's encountered as a powder or as in fake or counterfeit pills. I think we've all seen the news of the seizures and so forth, the fake pills, well, you can see here the blue M30 oxycodone tablets. And so, especially per the DEA, they're carrying out their one pill can kill campaign, and they estimate that 2 out of every 5 counterfeit pills that they seize contain a lethal dose of fentanyl. And a lethal dose, we'll get into that. It's not a lot, it's 2 milligrams. We're not talking about a lot. It can be injected, snorted, smoked, or taken orally as a pill. And then the figure on the right just shows when you isolate all drug deaths in the county versus those involving fentanyl, again, the predominance of fentanyl-related deaths in recent years.
If I am going to deal drugs, I would think I would want the person I was selling to live so they could buy more from me. I don't understand why there's so much fentanyl put in that kills people. I mean,
That might be a question for law enforcement to answer about. Oh, I have a few slides talking, and Sergeant Hotz could speak to that. You want to? Is that now or I don't know?
Yeah, it's up to you. Do you want to come up now and answer that question? Sure. We can go ahead and take you now. All right.
I go here, up front?
Yeah, right there.
Yeah,
My name is Mike Haas with with Metro Police Department Specialized Investigations Division. It may not be, council member, an overt act to say, I want to kill this person by selling them the drugs. It's more of a reckless type action where a lot of the drug dealers realize that the end result of them selling their drugs will be someone getting addicted to the drugs, which creates a repeat customer, for lack of a better term. However, the methods in which they're distributing these drugs, with particular emphasis on these counterfeit pills that Josh has a picture of. Another one would be counterfeit, what they call Xanax bars, which is actually just fentanyl, a small amount of fentanyl mixed into a pill. Those types of pills, fentanyl specifically, needs to be manufactured in a industrial pharmaceutical setting with extreme controls, quality of the product going into it, quality of the amount of the product going into it. And the way that these counterfeit pills are being manufactured, they are not being manufactured with the care, with the industrial pharmaceutical quality control that's necessary to dose somebody with a specific amount of fentanyl, which only a small amount is needed to cause death in someone. It's more of a reckless act of the person to distribute these drugs where one pill may have hardly any, if any at all, fentanyl, and another pill would have easily a fatal dose, if not triple or quadruple a fatal dose.
So it's a quality control issue.
One of the many issues, council member.
All right, thank you. Oh, and Councilwoman Hurt.
So I just wanted to bring some reality to the conversation and just answer the council member's question in terms of that. That's why we're seeing so much absence of Narcan, because it's going away quickly, because they know that the drugs may be laced with fentanyl, so they get Narcan right along with it in order for them to counteract it, so they can live again to get some more drugs. So it's like they're doing it, and then they know that they could die, but the addiction will make them hurt for it, and they want it, and they're going to continue to do it. So that's the vicious cycle.
Thank you.
Great question. Thanks, Sergeant Hotz. So I think we touched upon this a lot, but there's some graphics here that really help illustrate, again, why fentanyl, in addition to Sergeant Hotz's information, But again, these materials can be purchased online or directly from chemical producers. They're highly potent, cheap and easy to manufacture, and you can transport small amounts for large profits. Apparently, 1 kilo or just over 2 pounds is enough to kill 500,000 people. The figure in the bottom left shows the profit margin. Now, this is like from another area, but the idea is the same, that if you bought $1,000 worth of heroin and $1,000 worth of fentanyl, with heroin, you're going to make a profit of $4,000. With fentanyl, you're going to make a couple $1 million. So the profit margin is not even close. And that also underscores why someone would, sell. The picture on the right just are demonstrations of the actual quantity we're talking about. So the top right shows a lethal dose of heroin compared to a lethal dose of fentanyl. It speaks for itself. And then another image showing a lethal dose of fentanyl next to a penny. And so to Sergeant Hotz's point about quality control, you're talking about people pressing these pills. You can't feasibly cut an appropriate amount of fentanyl if you wanted to. It'll clump together. We're talking about such minute amounts. It's just dangerous stuff. Yeah. So this will also reiterate this counterfeit pill epidemic that we're seeing existing within the overall epidemic. This table shows what was seized by law enforcement who are conducting this drug monitoring initiative in another part of the country. So what it was described as versus what was actually found in toxicology. And it speaks to how, unless the take home here is, do not take any pill that has not been prescribed to you directly by a physician. That's where we're at now. And I'll go through a few of these, but for example, the top one, a suspected Percocet, was actually found to have heroin, tramadol, which is a synthetic opioid, fentanyl, and then 4-AMPP, which is a fentanyl metabolite, so essentially more fentanyl. As we showed on the previous slide, for the second row, round the blue M30s, a suspected oxycodone, were actually pure fentanyl. Another seizure of suspected oxycodone was fentanyl. And then the fourth row, a blue M30 again, had fentanyl and fluorofentanyl, which is an analog, and we'll touch upon, but that's an analog that's now in our environment here in Middle Tennessee. And I believe it's equipotent or similar potency as fentanyl. We put out an alert, our program last year, about an increase in ecstasy-related deaths as a collaboration with our partners in police. Those, a lot of time of suspected ecstasy or Molly or MDMA turn out to be pure methamphetamine. So on that side of thing, it's not the stimulant that you suspect you're getting. But that's, yeah. So I know this is getting really in the weeds, but bear with me. But it bears mentioning of what we're dealing with, again, in terms of the complex and ever-evolving nature of the substances that are coming into the environment. Especially in the synthetic age, there's just a lot of different, almost like endless types of substances that can be made up and distributed. But to start with fentanyl analogs, what are they? They're chemically related to fentanyl. They have similar effects, but they vary greatly in potency. So for example, I don't know if you guys have heard of it, but it's called carfentanil. So we talked about how potent fentanyl is. Carfentanil is 50 to 100 times more potent than fentanyl itself. So when we detect that in the community, and thankfully we haven't in a while, several quarters, that's a very serious issue. Since 2016 in the county, we've detected 10 different types. Some, again, are slightly less potent than fentanyl itself, some slightly more potent. Most common being acetylfentanyl and then fluorofentanyl. And that's what the figure shows on the right is the emergence of fluorofentanyl, and now it's almost our most common analog that we're finding. So that was initially detected in the third quarter of 2020, and now we're just regularly finding it. So it shows you how these analogs can come in and out of the drug environment, and so it bears monitoring these substances very closely and in a timely manner. Benzimidazole opioids, or aka nitazines, this has been a more recent substances, but they're synthetic opioids, again, varying potency and effects similar to other opioids. And this increase has been reported across the country. They've even, so this one's interesting. Originally synthesized in the 50s by a Swiss chemical company. They exhibit a high potential for addiction. They produce, analgesic or pain-relieving effects. Protonidazine and metonidazine were detected in fatal overdose cases in Knox County in 2021. So we can almost assume that it's at least in the state, if not in the Middle Tennessee area. Protonidazine is 200 times more potent than morphine, or 3 times more potent than fentanyl. And metonidazine is 100 times more potent than morphine. So it's not like the substances are getting less potent, unfortunately. Xylazine is a sedative with analgesic and muscle relaxant properties that's approved for veterinary use only. It emerged in Puerto Rico in the early 2000s, is often laced with heroin. Its Spanish name just essentially translates to horse anesthetic. And so it's been increasingly present in all 4 census regions in the country. As you can see, we had our first case detected in April 2019 here. And the figure on the bottom right shows how the number of cases have increased since. And 100% of those cases had a co-detection of fentanyl in the toxicology report. So just, again, very potent substances that we're finding. And then finally, to talk briefly about prescribing trends. It's almost after the fact these days, but it's important that we continue to look at it. So as I said earlier, the prescription drug monitoring programs largely curbed overprescribing. But what we saw was then an increase in illicit substances that we're mitigating today. But across all the different drug classes, we've observed a decrease over this 5-year period, except for buprenorphine, which we talked about, or MAT, and then stimulants, such as, I believe Adderall is a type of stimulant that you can prescribe. So we've seen slight increases in those. So that's something we're obviously going to continue to monitor. Okay, we're going to switch gears from data. So that's probably a lot, but you guys have any questions at this point? Or?
I actually have a question. So I want to go back to, you were mentioning I believe you said we were the 30th highest overdose deaths in the country?
Yes.
And so is there any other Tennessee city or county that's a higher rank than us?
Yeah, so from that database produced by CDC, Shelby was 28th during that time period. And I believe Knox was in the 46th. But those tend to be in the whole state, the 3 most active counties. Of course, when you look at Middle Tennessee as a whole, being a large metro area, tend to share most of the burden. So it's usually found in Shelby, Middle Tennessee, and then out east. Yeah.
Okay, thank you. Councilwoman Hauser?
Yeah, as we're looking at the manufactured drugs, does that mean that the danger is within our country rather than coming across our borders? Because I know, years ago, we looked at our borders and we were trying to stop things from coming in. But now that it's being manufactured, is that more, not so much a border issue, but more within our own country issue?
This is out of my scope to discuss. I'll rely on my colleague in law enforcement, if you don't mind, one more time. He can speak better to it.
I would say that a significant portion of the counterfeit synthetic pills that we're seeing, as well as the powdered fentanyl that we have interdicted as a police department, in our region of the country, I would say largely are coming from the southern border. There are certain amounts that are also coming in from the East Coast, but I would say, based on my personal experience, what I've seen, there's a significant portion that's being brought across the southern border and then directed towards Middle Tennessee in different fashions. Some are being brought here by the traditional courier type method where somebody drives it. Others are through different postal services such as U.S. Postal Service or FedEx, UPS, DHL, and the number of these drugs that are reaching Nashville, our city, are staggering. Just, I would say a couple weeks ago, we did an operation and interdicted a plastic vacuum sealed bag that was full of counterfeit Xanax, marketed as Xanax bars that were laced with fentanyl, many of them likely fatal, and that vacuum sealed bag was large enough to fit inside of a shoebox. It was a significant number of pills. And the amount of powdered fentanyl that's coming in kilo quantities is also staggering.
Thank you. Any other questions for Josh before he carries on? Okay.
So yeah, we're going to shift gears from data just to talk briefly about our program at the health department and some of the activities we're doing, some efforts, a brief conclusion, and then a call to action, which is largely aligned with some of the strategies I presented at the beginning. So our program, we've grown over the last, I'd say, 4 years, largely grant driven. So I work under a Department of Justice grant, so I'm focused on enhancing data and surveillance and data sharing amongst public health and public safety. So we have 2 epidemiologists, 2 coordinators, a social worker, and a director of our program. We've also recently received a NACHO grant for the Community Overdose Prevention Empowerment Project to get community voice incorporated into overdose prevention strategies, which will be great. And then a SAMHSA Gains Sequential Intercept Model Workshop, which involves a large multi-sector group of stakeholders to focus on the criminal justice and behavioral health systems. So we're really excited about that. Just a visual showing kind of who we work with in the different sectors. Again, I've mentioned multi-sector several times, but it really does fall under political, public health, forensic science, et cetera. And we operate at the local, state, and national level. So we have partners across the board. Anybody who works on this issue, we're trying to engage with and just compare notes, essentially. We have an overdose fatality review panel, which has been stood up for well over a year now. And so those are set forth similar to an infant mortality review panel to identify system gaps to improve things. And then I'll kind of skip through some of this. But there's a rapid linkage treatment pilot currently at the emergency departments that was implemented in December 2021. So we're going to be monitoring that and seeing how that's going. One of our grants is between the Tennessee Department of Health and the CDC. It's a high impact area grant. So it covers Cheatham, Rutherford, Montgomery, and Davidson County. So for that, we have as one of many efforts, a large stakeholder group from local and regional partners to delve into the different parts of this epidemic. The EMS here has been conducting post-overdose follow-up for well over a year. So anytime an individual overdoses and they have an email or phone, they have a dedicated staff member who attempts to follow up with them within 72 hours and link them to treatment, such as the mental health cooperative. So that's been really fantastic. We conduct data to action resource targeting with public safety, and then Dwayne Holman's going to come up in a minute. He works for Nashville Prevention Partnership and the Regional Overdose Prevention Specialists, or ROPES. Obviously, we're conducting drug overdose monitoring and surveillance. We have a data system which tries to analyze information for all different sectors. We stood up an acute overdose response plan, which drives the spike alerts that you guys might have seen in the news, but it allows us to detect, analyze, and then communicate out these incidents as near real time as we can to potentially mitigate more harm. And also as a part of that's the Spike Auto Text program, so where you opt in, you receive a text. There's a syringe services program here in the county operating at 3 sites. So their syringe services programs offer a variety of services, but the health department in collaboration take in the needles as medical waste for disposal. So that's been going on for a few years now. A lot of this is data driven. As part of one of the grants I mentioned, we're collaborating with the Coptic Christian Church community, and then SPAC, which is the Suicide Prevention and African American Faith Communities Coalition. And then, yeah. So conclusions, and then I'll try not to step on Dwayne's time any more than I have. But conclusions, this is a public health emergency. Davidson County has experienced epidemic level overdose activity with escalating overdose injury and death. Overdoses present an unyielding and significant impact on the community, healthcare system, first response, recovery treatment, and most importantly, affected friends and family. That's who's really impacted by this, and we don't forget that. It's expected to continue, especially with the synthetic age, as you saw with the different substances that are just always coming about. There will always be a potent substance in the community, especially with fentanyl causing a paradigm shift. We implement a data to action approach with our program, so we have timely information and we can use that to drive community response with our partners. And as I've iterated several times, this involves multi-sector public-private partnerships are key to mitigating this multifaceted and constantly evolving epidemic. A few calls to action that we developed, prioritizing funding for acute response efforts. We've all seen the success of the Partners in Care project, which has been really excellent. Supporting primary prevention and harm reduction strategies. Mary Linden talked a lot about this, about legislation that's coming down the pike or is soon to hopefully be passed. You can support those initiatives, be trained in and carry naloxone, especially if you know a loved one who's at risk. Encourage local businesses and constituents to carry naloxone. This isn't a plug, but if you want to receive timely information to your cell phone, subscribe to the auto text program, and you will get a text as soon as we activate an alert. In terms of recovery support, providing support for people living with addiction or in recovery, and then encourage businesses to be recovery friendly, support those policies. And then consider opportunities to expand treatment options. And then stigma, it's a very large subject, but to continue to support decriminalization of behavioral health, including persons with mental health and or addiction crises. And then potentially utilize the policy systems and environment's approach to shift cultural norms. There's some references, so I didn't make it up. And there's my contact. Just feel free, if I haven't presented something here and you want to see it, I might be able to find it or find the data on it. So just email me and I'd be happy to talk about it. And then there's our website. We put a lot of information out there, not just the quarterly reports, but public health and safety advisories and other resources, such as the Tennessee Red Line, the Community Overdose Response Team with the Mental Health Cooperative, et cetera.
Thank you, Josh. Is there any city in Tennessee that's declared a public health emergency at the local level?
Not that I'm aware of,
Thank you.
but there could be.
All right. Thank you very much for your time. We're going to bring up Dwayne Holman from the Nashville Prevention Partnership as our final speaker. Thank you. Welcome, Mr. Holman, and thank you for being here. Reuniting with Councilwoman Hurt.
We go way back as well.
Thank you. Okay. Good. All right, turning it over to you, Mr. Holman. Thank you.
Thank you. Thank you for having me here. Very encouraging to see all of the good work that we all have done collectively. The good news about what I'm about to say is that it really does dovetail well with what Mary Linden has said, also what Josh has said earlier. So again, my name is Dwayne Holman. I'm the Executive Director of Nashville Prevention Partnership. Nashville Prevention Partnership is a coalition of entities, organizations, individuals that what we basically try to do is bring people together, and we try to solve some of the various issues that we have. We have some very strong partners in the Metro Health Department, also TADIS, Metro Nashville Police Department, Fire Department, Streetworks, STARS Nashville, and there's the list kind of goes on and on. What we have done historically is what the Metro Health Department now is doing to a much larger extent with more resources, that is to pull these entities together. But what I want to talk about specifically is the regional overdose prevention specialists that we have on our staff. We have 4 of them in our county. We have more overdose prevention specialists in our county than any other county in the state. What they do is they actually train our citizens in this county. One, what what an overdose is. So they'll talk a little bit about the overdose crisis. They'll talk a little bit about the what naloxone is, how it's utilized, and the other thing that they do is they actually distribute the naloxone. So we have distributed in the state. There's been over 26,000 lives that have been saved due to using naloxone or Narcan, as you all know it. And there has been over 206,000 units of Narcan that's been distributed. A lot of that distribution in the city of Nashville, Davidson County, goes to street works, goes to the Nashville Fire Department, goes to the police department, and places like the mental health co-op and some of the other places that actually has who see people on a regular basis, even some of the recovery housing units, things like that. What we're trying to do is we're trying to get the naloxone in proximity to where people have the greatest need. And we have that in some of our strong partners across the state. And of course, here in Davidson County is no different. We have distributed over 15,000 units of naloxone here in Davidson County alone. In your package, you'll notice a number. It is 615-393-6980. That is the number that you need to call or have your constituents call if they want to receive training on how to use naloxone or Narcan. And also, we do have, as I said before, a limited supply of Narcan that we can actually distribute to as well. So if you know of someone who is in need of that service, feel free to give that number a call. We have 4 regional overdose prevention specialists in Davidson County in the city of Nashville. I'm not going to go over all of this information because you've already heard some of this stuff, but just to give you kind of a primer here of what's in here. There's resources describing where you can potentially go get Narcan if you're not eligible to get the Narcan that we get from the state. It also talks about the faith-based initiative that we work with along with the Project Lifeline, which is another program that we run out of Nashville Prevention Partnership. Also, one of the sheets talks about what naloxone actually is, the Good Samaritan Law, and the Tennessee Addiction Treatment Act, and how that protects and what the limitations are in terms of protection for our citizens. We also have a little bit of a guide on fentanyl exposure, and we also have a sheet about the spike alert that Josh just informed us about. No packet would be complete if we didn't talk about the red line, so we do have information on the red line in there as well. So just feel free to review that. Again, I don't want to take up any more of your time. I just want to make sure that you all were aware of the resources that we had available here in the city of Nashville.
Thank you. And I've got a question kind of target. You were mentioning training.
Yes, sure.
Should residents or faith groups or whomever would be contacting you, is there a certain size that is the ideal training size when having this type of session?
Yes, the ideal size is 1 to almost any other number.
Oh, okay.
So yes, there's actually no ideal size. We have trained, upwards of 100 at a time now. To be honest, that is a little bit large. We do like smaller groups because we do want to make sure that people understand what they're getting to. So usually about 25 to 30 people, but we have trained 100 people. We've trained as much as 200 people, I think is the largest that we've had. So yes.
Very good. How about questions for Mr. Holman, either of you? No? The question I have really kind of ties in, I think, between you and what Mary Lynn and Salter were talking about, really related to the legislation that is, going to make naloxone, potentially more available. How would that work in conjunction from a data perspective? Like with COVID, home-based tests made, our numbers probably always a little bit off once those became more available. So with naloxone being more available potentially to people to be able to buy, how will that impact the data collection component, that would be a part of what Josh does? Do we have any insight about how that might
Mary, you want to address this? And I can maybe talk about it a little bit as well, and maybe Josh.
I'm not sure this is what you were asking, but one of our talking points around the naloxone bill was to compare states that had an open standing order for access to naloxone to states that didn't, and the number of overdose deaths and the number of other kinds of interdiction activities went down. So I can't tell you exactly what's going to happen, but certainly that has been shown to be the case in every state that's gone to that practice.
I see. Thank you for that.
And again, the idea behind that is to get naloxone in proximity and easily accessible so people can have access to it. When I look at it, I think of it in terms of, think about heart attacks before we had the EAD passed. Think about some of the other things. My daughters, both of them have to carry EpiPens, you know, so think about it in terms of those kind of things. It's a life-saving step. Now, we may see also, as we have seen in other places, when people use their own naloxone, they may be less likely to call fire department. But again, the whole idea right now, we need to save people's lives, and so that's the thing that's most important. Now, one other thing I'll tell you as well is that, and we've seen this a little bit at our program. If you're in a real emergency, you really need to call 911. Don't call our number. I mean, obviously you can call our number, but the first thing that they're going to ask you is, are you in an active overdose situation, or is the person in that, and they'll redirect you to 911. Because those kind of things, we cannot help you with that, because that you know, that's what the fire department, that's what EMS is for. So we want to make sure that we're perfectly clear in making sure that people call 911. And then after that, then you still could call us to potentially get some more Narcan.
Very good. Councilwoman Hauser.
It was mentioned, I think with the last speaker, that after the Narcan being given, that within, I think it was 48 hours, there was a follow-up call. And I was wondering, during those follow-ups, do we typically have an opportunity to really connect with that individual and see if there's something that can be done to get them to a healthy point in their life? Or are we mostly just checking, are they still alive? Or, and I guess my second part of that is, if somebody has gone through that serious a situation of nearly dying, are they more likely to reach out for help, or are they so far in their addiction at that point that they may not?
Okay, so to answer your first part of the question, at the fire department, there's a person who's dedicated to actually doing follow-up. A lot of times they'll refer that person over to the mental health cooperative. Sometimes they'll refer them over to us so they can get training on how to use Narcan, and also you know, some other wraparound service. We'll sometimes get our lifeliner, who is a peer recovery specialist, to help them get into other treatment facilities as well. So that's one part of your question. If anybody else in the audience would like to take a stab at that, I'm happy to entertain that as well. But the second part of your question is, the way we think about it is that, again, Narcan is a harm reduction methodology that we use. So our idea is that we want to, you're not going to have to worry about treatment or anything like that if you don't live, if you're not able to actually experience life again. And so we're trying to triage them to where they can get to the point to where they can get to treatment, where they can take advantage of some of the resources that we have. That may occur over and over and over multiple times, just because that, as you heard Mary Linden talk about how it affects the brain and how strong and powerful it is. It may take a while before someone gets to the point to where they're actually able to experience recovery, long-term recovery at that. Yes.
Councilwoman Hurt.
I'll take a stab at it too, because I'm really proud that one of my employees is the one that recommended the follow-up at a meeting, because the fire department was not really looking at that. But when they do follow up and they put them in contact with mental health co-op, as Dwayne said, they do link them to care, whether it's for mental health or what other kinds of care. Some of them need housing. There's so many things that they need in terms of wraparound services. And as far as them wanting some help, that goes from day to day. One day they want it, the next day they don't want it. We put them in there and we would go over and over and over again. But you have to continue to do it because they need it. So, and we win some and we lose some. But as Dwayne said, the most important thing for us is to save their lives. So that's the first thing that we do, is provide them with the Narcan in order for them to still be alive. Does that make sense? And I know your heart goes out and you want to see and think that it should be better, and it should, but I promise you the work that the Nashville Prevention Partnership, the Health Department, Mental Health Co-op, it is changing lives. It is saving lives. The work that they're doing is invaluable. You just would not believe it. But a lot of people are out here very, very ill. And you just don't know it, but they are truly making a difference. And thank you. I want to thank you and thank the Health Department and the Tennessee Health and Mary London and all of the work that you're doing, because it is making a difference in our community. And our surrounding communities too, because a lot of people don't know that people come from all different counties to get services.
Thank you, Councilwoman Hurd. I appreciate your time, Mr. Holman. Thank you so much. I know I've kept you guys over, but I would really like if one of our representatives, Mr. Chalice or Mr. Connor, would you be able to come up to the back mic and share just a high level about the opioid settlement, since everybody's here? Thank you so much.
Thank you, Councilmember Evans. And I'm here with our co-counsel, Isaac Connor, as well, from Manson Johnson Connor here in Nashville. So Metro Nashville has taken a lead role in the national opioid litigation. This is the litigation against the opioid manufacturers, distributors, and pharmacies who have contributed to causing the opioid crisis that we're here talking about today. It is true it has evolved into what is now a more fentanyl-based crisis, but the origins go back to prescription opioids, and that occurred over decades, over a generation or more. It passed through a heroin phase, and now we're into this fentanyl phase, but the origins, unfortunately, started in the boardrooms of corporate America, and we're now dealing with it in our communities. So the litigation has been so far fairly successful. It has resulted in a historic settlement with the large distributors of opioids and other medications, and one of the large pharmaceutical companies, Johnson & Johnson. It ultimately has resulted in a roughly $26 billion settlement. Nashville has had a seat at that settlement negotiation table all throughout. Nashville is, through its representatives, serves on the plaintiff's executive committee in that litigation. And there have been, throughout the process, various members of the administration involved in that negotiation. In particular, the negotiation with the state government, state attorney general, and the legislature, that was led in principle by the Metro representatives. So the great result, which will ultimately lead to almost $24 million coming into Nashville at no cost to the city. Mr. Connor and my law firm, we've agreed to waive our contract with the city for our fees, and instead we're going to apply for payment to a national settlement fund. So in other words, any fee we get paid does not come out of any money that would otherwise go to our community. And so we're grateful to Mayor Cooper. We're grateful to the Metro Legal Department and Mayor Cooper's office as well. And before I conclude, I just wanted to mention as well that the a large portion of the settlement funds are earmarked, not just in our community, but nationally and statewide. They're earmarked for abatement purposes. So a lot of what we've talked about here today and a lot of the programs that we're talking about here today will benefit from this settlement. And that money will be usable for these abatement type uses. And Metro's various departments have contributed to that process by helping us craft an abatement plan nationally that would that prescribes certain categories of spending that this money can be used for. So beyond just our community, and it's flexible so that each community can formulate its own response unique to its own community needs. But Metro played a significant role in that, and will continue to play a significant role in this litigation. So. Congratulations to this administration and to the council for its great work, and it's resulted in really meaningful change that will occur over generations in our community.
Thank you very much for sharing your expertise with the city and your willingness to go for that national settlement. I know we all really appreciate that, so thank you for your sharing the information about the settlement. There was a press release that went out from the mayor's office about it today, so you'll likely see more stories on the news about it as well. So with that, I've kept you over for too long, so I really appreciate everybody's time. Hopefully this is the first of other conversations that we'll have as a council body about fentanyl and dependence, and we'll be able to come back together to talk more about these issues going forward. So thank you all to all of our speakers for coming, and with that, we're adjourned.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.